So this is the University of Colorado. This is where I currently am practicing pathology. I did get the privilege of coming here for my residency, so we started at the 9th Avenue campus, which was almost downtown when I was a resident. And then about 6-7 years ago, they built this beautiful new campus that's still being built, still up and coming, and I had the privilege of staying on as faculty at this new campus. So when asked to put together this talk, I tried to come up with some questions that I thought that you might have for a cytopathologist, because many people, cytopathology and pathology in general, it's just a name on a report. It's a report that you receive, and there might be this disconnect for the fact that there really is a physician that's at the other end of that report who's putting a lot of thought and a lot of time and a lot of interest into the specimen that is procured and what goes into that report. Because the cytopathologist and the pathologist in general for any surgical or any anatomic procedure really is an integral part of the multidisciplinary team. But in some ways, we're kind of behind the shadows. You know, we're in the black box that nobody really sees us and knows what we are doing. So I put together questions that I thought you guys might have for me. If I am completely off base, and these are not the questions that you want answered, please feel free to, redirect this session to where you want it to go. What do you really want to know about cytopathology? So my first question was, again, what is cytopathology and who are cytopathologists? What do they do and how does this relate to me? Second, what is a thyroid fine needle aspiration? And I know that many of you have personal experience either undergoing a thyroid fine needle aspiration or family members and loved ones and friends that have undergone a fine needle aspiration. But what is it that the cytopathologist wants from a thyroid FNA? What are we looking for? What does the diagnosis mean? When we give you a malignant diagnosis, how confident are we that this is malignant? Likewise, if we give you a benign diagnosis, how confident? Where did that diagnosis come from? And then the one that is probably the most intricate and complicated is, what is this indeterminate category, this indeterminate diagnosis that so many people feel like they fall into, and where do I go from here? Like, how did the cytopathologist get to this? How did the clinician get to this, and where do we go from here? And then one question particularly, if you're one of the people that have ended up with a indeterminate clinical diagnosis, should I consider a second opinion from a cytopathologist or from a pathologist? Do I take my pathology and go somewhere else and ask for other opinions? So these are the questions that I thought you guys might have for me. Like I said, if this is completely off base and these are not the questions you want answered, feel free to interrupt me and we'll move this in the direction that you want to go. So a couple of definitions, to get back to that original, what is a cytopathologist? What is a histopathologist? So histopathology, this is the diagnosis based on microscopic visualization of whole tissue sections. So that means if you undergo surgery and you have your thyroid taken out, the thyroid is sent to a pathologist who literally takes the thyroid and chops it up into little slices, and these slices of thyroid tissue are embedded on a slide. So when a pathologist is looking at a whole tissue section, they get the architecture of how the cells relate to each other. Cytopathology, by contrast, is the diagnosis based on the microscopic visualization of single cells and very small tissue fragments. So how do we get these single cells and small tissue fragments? Like many of you have experienced, you can get it from aspirations. You put a needle in something, you collect the single cells, and then you spread them out on a slide. And on the slide, they come out as either single cells or little tissue fragments. Another way to get these single cells is by scraping. So many of the women in the audience have probably undergone the Pap test. That is actually exfoliative, that is scraping of these single cells, and that also would be looked at by a cytopathologist. So the pathologist that's looking at whole tissue sections is a physician that has 4 to 5 years of residency training in the diagnosis of tissue. A cytopathologist, by contrast, is a pathologist who then undergoes additional training, 1 to 2 years, additional board certification to examine these single cells and small tissue fragments. And that's not to say that many anatomic pathologists that don't have additional board training in cytopathology are not good at cytopathology. They are. Many of them have abundant experience and are quite capable of looking at cytopathology cells because that's part of the initial training. But when you have a board-certified cytopathologist looking at your specimen, you do have somebody that has that additional 1 to 2 years of focused training looking at single cells and on slides. So the joke that anatomic pathologists have with cytopathologists is that we are merely looking at tea leaves, we're looking at how the tea leaves come together, and from this we are coming up with a diagnosis. But in reality, what we're looking at are cells. So I thought I would give you guys an example. This is an aspirate that is taken from a benign thyroid nodule. And things that we look at here are the nice uniform appearance of the cells. Each cell looks just like its neighbor. The nucleus is round and oval. They're not overlapping. And in the background, we have abundant colloid. So benign thyroid nodules typically produce colloid. So we see colloid in the background and then benign macrofollicular groups of cells. So moving on to thyroid fine needle aspirations, what is the utility of thyroid FNAs, particularly from the perspective of both the patient and the clinician? Obviously, thyroid fine needle aspirations, or perhaps not obvious, but in the medical community, thyroid fine needle aspirations are the gold standard for the initial diagnosis of thyroid nodules. And these are thyroid nodules that have come to attention either by palpation, so they have a clinical suspicion, they're large in size, or they're radiologically considered indeterminate. So sometimes the radiologist can look at the thyroid and say this is clearly a benign nodule, and sometimes the radiologist can look at the thyroid and say this has a high suspicion of malignancy. And those are the ones that are going to go to an aspiration, but also the ones that radiologically are considered clinically indeterminate. So characteristics that would throw that into clinically indeterminate would be something like microcalcifications or peripheral vascularization, or perhaps just the size of the nodule. So these are nodules which then undergo a thyroid fine needle aspiration, which, like I said, is considered the gold standard for making the diagnosis of thyroid nodules. But that's not all that thyroid fine needle aspirations are useful for. Certainly pre-surgical evaluation of lymph nodes. So it's really important for the surgeon to have an adequate understanding of what is the status of the cervical lymph nodes. Has the patient already undergone metastasis? And if so, the surgeon can use this information to direct the extent of the surgery that they're going to perform. And then a final utility of fine needle aspirations in general, and not just limited to the thyroid, is to look for post-surgical evaluation for recurrence and metastasis, even to more distant sites. So we can look at the lymph nodes post-surgically and see, do these look atypical, and if so, we can aspirate it. And likewise, in evaluations for metastasis to a distant site, aspirations can be utilized at any place in the body to look for metastatic disease. So here you see a thyroid fine needle aspiration being performed under ultrasound guidance. And fine needle aspirations can be performed either by palpation or by ultrasound guidance. Typically, we use ultrasound guidance really to ensure that the needle is in the nodule of interest. So you can visualize the needle under ultrasound and make sure it's in the nodule of interest. And likewise, you can use ultrasound to make sure not only that it's in the specific nodule that you want, but the specific component of the nodule that you want. So if a patient has a multicystic or a solid cystic nodule, ultrasound is really beneficial to make sure that the needle is sitting in the solid component of the nodule, because that's where the pathology is more likely to be relevant. And then once the needle is placed into the solid component of the nodule, the technique is to very, very rapidly move the needle back and forth in this coring motion. So if you've had the experience to undergo a fine needle aspiration and you remember that the operator was very rapidly poking back and forth almost like a sewing needle, it's not because the person is incapable of doing a fine needle aspiration. In reality, that is the best technique because the sides of the needles are used to cut through the tissue and collect the cells up into the hub of the needle. And it is that key motion that is really, it's that rapid motion that is key to successfully collect adequate tissue. So, like I said, thyroid fine needle aspiration is accepted as the gold standard for evaluating thyroid nodules, but let's look at some statistics to understand why this is the gold standard. So this is a conglomeration of several studies, and based on numerous studies, the rate to obtain a satisfactory specimen is greater than 95%. Likewise, fine needle aspiration has a very high positive predictive value. You can see here, upward of 80 to 90% or 90 to 100%. A very high negative predictive value and low false negative and false positive rates. So what this is showing you is that this is a very accurate test, meaning that if you get a diagnosis of malignant, the rate of malignancy truly is high. The chance that you have a malignancy is high. And if you get a diagnosis of benign, the chance that this lesion is benign truly is high. The question then is, why do we see such a range in the sensitivity from approximately 50 to 100%? And the range in sensitivity reflects a number of variables that are involved in both the procurement of the specimen, so this is including the skill of the person that is taking the fine needle aspiration, the skill of the person who is preparing the slides. So how is that aspiration prepared? And then finally, this variability reflects the cytopathologist that's looking at the slides, and how do they classify the diagnosis into indeterminate, into suspicious, into malignant. And we're going to kind of spend the bulk of the talk talking about that. But then I'm sure the question that all of you have is, how do I make sure, if I am undergoing a fine needle aspiration, that I end up in that high sensitivity side? How do I make sure that I get a good fine needle aspiration? So some important things to consider here. One, operator experience. Who's doing the aspiration, and do they have abundant experience doing fine needle aspirations? And remember, there really is no harm in asking questions. How many of these have you done before? Do you have a lot of experience doing these? Do you do these every day? Do you do these one day a week? Another question to ask, and probably just as important as who's actually performing the procedure and doing the aspiration, is how are my slides being prepared? Who's doing the preparation? Do you have a cytotechnologist that comes and makes the slides, or do you just do you have experience making slides yourself? So generally speaking, we assume that larger institutions, especially academic facilities, will have experienced cytotechnologists and staff that know how to prepare the slides. But in reality, many smaller hospitals and clinics also have abundant experience in doing this. So if you're going to a smaller clinic, that doesn't mean that you do not have access to a cytotechnologist that's making these slides and preparing the slides for you.
That's a question.
Yes?
So would you recommend, I've had this done at places like large imaging places like Sally Joe,
Mm-hmm.
and at universities and at hospitals. Do you feel like their level of accuracy is equivalent to large imaging companies?
I do. I feel like what you're looking for is an institution that does a lot of these. So if you're at a large imaging institution and they have abundant experience in thyroid, then you're good to go. If you're at a large imaging institution but they specialize in, neuroradiology, then that's probably not the right place to have your thyroid looked at. So really it's experience. How many have they done? The other question that you can consider is how many passes are being taken. So many places, such as our institution, we're an academic institution, and we do something called rapid on-site evaluation. So if you go to the endocrinologist or to the radiologist and have your fine needle aspiration performed, they will take 2 to 3 passes, and then they will ask a cytopathologist or a cytotechnologist to come and look at these passes and evaluate for adequacy. If there's not enough material on the slides at that point, without having to undergo a second procedure, the operator, the endocrinologist, or the radiologist can go back immediately and get additional passes. Keeping in mind, though, 3 to 6 passes for a thyroid is sufficient. Any more than 6 passes on a thyroid, and diagnostically, at that point, the specimen is going to be so obscured by blood that it will hinder the evaluation. And the consensus is really no more than 6 passes on a thyroid, because at that point, the material that you're getting will no longer add to the ability to make a diagnosis.
Not sure what you mean by pass.
So a pass would be an initial time that the needle is placed into the lesion. So one pass would be, one needle into the thyroid nodule, second needle into the thyroid nodule. So any more than 6 into a thyroid, and it's time even as the patient to say, I'm done. And yes, ma'am.
So the needle comes out with each pass?
Yes, ma'am.
With tissue.
With tissue. So the way that it's performed is the needle goes in, and the operator performs that very rapid kind of sewing needle type, keeping the needle in the lesion. So they'll numb up the thyroid, they'll keep the needle in the lesion, and they'll still do this rapid back and forth motion.
Would you define lesion?
Lesion is anything of interest. So the reason I'm being ambiguous about lesion is, in the case of a thyroid, it could be a thyroid nodule that is of concern. But it could also be a lymph node that's of concern. It could be a lesion in the liver that's of concern. So anything that the clinician wants to put a needle in and find out what are these cells, we call a lesion.
In a week, I'm going to have a third biopsy, and I'm also going to do a permanent.
Mm-hmm.
And I think the doctor said it would be like 6 to 8 these passes. Is that going to work with a permanent?
It will. Typically what they want to do is, when you're doing Afirma testing, they want to first put a needle in and hand it to a cytopathologist or a cytotechnologist to make sure that they are in the area that they're concerned about. So if you're going for Afirma testing, they've already looked at this thyroid nodule or the metastasis, and they're concerned about this. Afirma is not typically used for a MET, but they've already looked at it. So the first or second pass is to give to a cytopathologist and say, do we have the cells of interest? And then they will do 1 to 2 passes more that go directly into a special media that is sent for molecular analysis for Afirma. I would argue the same thing. 6 passes is enough. Once you get to past 6 passes, the specimen becomes so bloody because the thyroid is a very vascular organ. And you can be the best operator in the world. You start putting a needle in something that has a lot of blood vessels, and you're going to end up with a lot of blood. So your second, third, fourth pass, one of those should go for Afirma testing. Other things to make sure that you get a good fine needle aspiration. Don't hesitate to ask, where are my slides going? Who's going to review these? Are they going to a pathologist? Are they going to a cytopathologist? I would argue that ideally the answer you're going to get is they're going to an experienced board-certified cytopathologist who has experience looking at thyroid fine needle aspirations.
Who do you ask these questions to?
You can ask these questions to the person doing the procedure. So the person doing the procedure is a doctor, is either an endocrinologist or a radiologist, and they should know where these specimens are going. If they don't know where they're sending their slides, then there is definitely something wrong. And that kind of leads into the next question. Oh, yes, ma'am.
I was just going to ask, I get all my care at entrance.
Okay.
So I'm assuming that I'm good on all these.
You are great on all of these. If you get all your care at Anschutz, you're either seeing our radiologists who are absolutely fabulous, Dr. McKinney and Dr. Patel, or you're seeing our endocrinologists who are equally absolutely fabulous. And you have one of us in the back room looking at your slides. And that kind of leads into the next question, the next point. This is probably, in my opinion, the most important thing, and this is one that is very difficult to assess, but I would say that most larger institutions have this, a good rapport between the pathologist, the radiologist, and the endocrinologist. And this multidisciplinary rapport is really important because although a cytopathologist renders a diagnosis based on the cytomorphologic features, we also render the diagnosis based on the clinical impression of the radiologist and the endocrinologist. We use it all together. So just like we tell our clinical colleagues, You wouldn't examine a patient without getting a clinical history. Don't do that to us. Give us a good clinical history so that when we examine the slides, which is how we examine a patient, we also have the information of a clinical history to put that together. And likewise, the endocrinologist and the surgeon, they can't adequately treat a patient unless what they get back from us is a fine needle aspiration report, which is unambiguous, clear, and clinically relevant. So all of these go together in a good multidisciplinary rapport where we discuss what is your clinical impression. This is what I see. What did you see radiologically? Does what I see on the slide fit what you saw radiologically? Because if it doesn't fit what you saw by radiology, then we probably need another specimen. So the whole picture has to fit. And this communication, this back-forth communication, is probably the most important aspect to getting a good diagnosis. So that leads into the cytopathology report. What do you want to see on your cytopathology report? And remember, as a patient, you have access to all of your medical records. Now, generally, pathology records are held for 1 to 2 weeks before, at least we do at the University of Colorado, they're held before put on the MedExplore or MedEpic or Health Med, where you can go and access all your records. And the reason pathology reports are typically held for 1 to 2 weeks is to give the clinician time to discuss this with the patient before the patient gets a diagnosis of malignancy. But nonetheless, you have access to your thyroid, to any of your anatomic pathology reports, including your fine needle aspiration reports. And you should get access to your reports and look at them. So what kind of things do you want to see on a thyroid cytopathology report? You want to see a statement of adequacy. You want to make sure that the diagnosis that's being made is made because there's enough tissue on the slide to make that diagnosis. So that's exactly what a statement of adequacy is. It says that there's enough tissue, there are enough cells, there's enough colloid here for me to make a diagnosis and be confident that this diagnosis actually represents what is in the patient. The second thing that on a thyroid cytopathology report that you're going to see is a diagnostic category. So we'll talk more about these 6 categories. And then within the diagnostic categories, you may have a specific diagnosis if possible. So it's not always possible. An example of that would be the diagnostic category would be benign, and then the specific diagnosis would be benign colloid nodule. Or the diagnostic category would be malignant, and then the specific diagnosis would be papillary thyroid carcinoma. So you can see how if you end up in this indeterminate, you may not have a specific diagnosis. If the diagnostic category is indeterminate, atypical cells of unknown significance, then you're not going to end up with a specific diagnosis, but what you should see on that report is a descriptive comment. There must be a reason why that pathology specimen was placed into an indeterminate category, and the pathologist or the cytopathologist should explain why they put it there. So perhaps it's indeterminate because although they see atypical appearing cells, there's not enough of those cells to come to a definitive diagnosis. Or maybe they see abundant cells, it's highly, highly cellular, most of the cells look benign, but then in the background they note, a few clusters of atypical appearing cells. So it's this comment that is going to help lead the clinicians, the endocrinologists, the surgeons, and any future pathologist that looks at these slides in the direction, where do we go next? How do we clinically treat? What is the next step? The pathology report may also have a recommendation. So if we feel like we see something that's atypical, but the sample is not very cellular, then the recommendation may be repeat thyroid aspiration. The recommendation might be ancillary testing, such as Infirma. The recommendation may actually be surgical excision. So a little bit of history. Prior to this conference, in 2007, the NCI, National Cancer Institute, hosted a 2-day conference in Bethesda, Maryland, and this was a multidisciplinary conference that included pathologists, surgeons, endocrinologists, anybody that was involved in the treatment of thyroid cancer patients. And prior to this conference, a little bit of history here is cytopathology reports were a little more free form. So the cytopathologist would kind of do a description of what they saw. And this worked great if you were at an institution that had a good rapport and the endocrinologist and the surgeons knew their cytopathologist and knew exactly what they meant when they said follicular lesion. But this proved to be a problem if then you decided that you were going to transfer your care and go somewhere else. So you were taking a cytopathology report that was kind of a free-form diagnosis to another institution that perhaps didn't really know what did that cytopathologist mean when they said follicular lesion. So one of the most important things that came out of this 2-day conference in 2007, at least in the world of cytopathology, were recommendations regarding terminology and morphologic criteria for diagnosis of thyroid fine needle aspirations. In other words, the small goal for pathologists at this meeting was to develop a standardized terminology so that when I call something suspicious for follicular neoplasm, you can take that diagnosis anywhere in the world and your clinicians will understand what I saw and what I meant by that. And these recommendations were later published as the Bethesda system for reporting thyroid cytopathology. And this is what we use now. This system clearly delineates these 6 diagnostic categories, which range from benign to malignant, and then they have the category of unsatisfactory or non-diagnostic. Sure.
Backing up a little bit, so when you take a sample, how many slides are prepared?
Excellent question.
If the initial impression is undetermined, you go back to one of the initial slides from the same sample?
So typically, for each sample, at least what we do at the university, and this is fairly standard, is we make 2 slides. We use 2 different stains, and the stains show different characteristics. So one of the stains are to look at the cytoplasm, and one of the stains are to look at the nuclear features. And then we take the additional cells that are in because typically when they get a sample, you have quite a few cells that are in the needle. So we make 2 slides initially, and then anything left in the needle gets put in what's called a wash. And the wash can either be used to make a cell block, or it can be used to send for a firma. It can be used in any number of ways. And we hold that wash because depending upon what we see on the slides, we might need to make a cell block. So for example, if the question is a medullary carcinoma, we want to take that wash to make a cell block and do special studies to prove that it's medullary. If by contrast what I see on the slides is completely benign, we don't even use the wash at all. So a lot of it depends. But for each pass, each time the needle goes in, what we do at the university are 2 slides. We look at one slide initially, and then we take the other slide back and prepare that and look at that, with more time at our desks. And then 3 to 6 passes is standard. So 3 is typically enough. So that gives a total of 6 slides to look at. If we need more at that point, doing a rapid on-site, we'll ask for more slides. And if we still don't have it after 6, we just stop, because sometimes something is so vascular that there is nothing that can be done at that point. Yes, sir.
Do you do anything with, say, I had a cystic lymph node, a bunch of stuff came out. Do you do anything with that stuff?
Yes. So lymph nodes are treated slightly different. We do the exact same thing with the cystic lymph node. We make 2 immediate slides, but the wash that we use for a lymph node, we send it for thyroglobulin studies, and that if the TG wash is positive, that is highly, highly suspicious for a positive lymph node. So, yes, sir?
If you have to repeat the aspiration,
Mm-hmm.
how many days do you wait?
Excellent question. Generally 3 months, 6 weeks to 3 months, because if you repeat the aspiration too soon, you're going to end up having cells. If you put a needle in the thyroid, you're going to activate these cells and make them look funny. If you repeat the aspiration too soon, if you do it before 6 weeks, your cytopathologist is going to call it atypical without hesitation, because these cells are going to look atypical just because they're reactive. So definitely a minimum of 6 weeks, 3 months would be better. The other thing to do is to make sure that the clinician, reports, and they should if you're having all your care in a single institution. As a cytopathologist, if I'm looking at something that I know is a repeat aspirate, then I know to be aware of reactive type changes. If I don't know that this is a repeat aspirate, I might be a little more concerned when I see those changes. So it's more likely to fall into the atypical finding. But having said that, over 50% of diagnoses that are considered clinically indeterminate, if you repeat the aspirate, over 50% of those will then be classified either into malignant or benign. They will have a definitive classification after repeating it. So this is a table that includes the Bethesda system. So we have the diagnostic categories on the right, the risk of malignancy, and then the management plan. And these 6 categories were constructed on the concept of the probability of finding a malignancy after post-surgical treatment. And then there's a management plan to go with this. And having said this, obviously each patient is unique. Each situation is unique. So if you find that you are in one diagnostic category, but that is not the management plan that has been recommended for you, keep in mind that every single situation and every patient is dealt with in a unique manner, because there are, unique characteristics to go into each individual. But if we look at this table, once again, what we see here is if you get a diagnosis of benign, your fine needle aspiration is quite accurate. The risk of malignancy, patients that have received a diagnosis of benign but then went onward to undergo surgery for one reason or another, a maximum of 3% of them found a malignancy in the thyroid, and many of those were malignancies that were not sampled. So an incidental PTC found somewhere else. Likewise with malignant, we are very, very good at making the diagnosis of malignant. Upwards of 100% of patients who have undergone surgery after diagnosis of malignant on a fine needle aspiration, and they end up finding the malignancy. Generally speaking, a diagnosis of suspicious for malignancy has a high enough risk so that the proper treatment plan here would be surgical intervention. 60 to 80% risk of having a malignancy if the diagnosis is suspicious for malignancy. It's the category of atypia of undetermined significance, or follicular lesion of undetermined significance, which we just kind of lump into AUS plus. And then this category of suspicious for follicular neoplasm that are considered clinically indeterminate categories. So by pathology, these are 2 separate categories. AUS plus is one category. Suspicious for follicular neoplasm is another category. And these have very different meanings in the pathology world. Clinically, these are lumped together as clinically indeterminate because the risk of malignancy here ranges from 15 to 30%. So the question is, what is the next logical step to deal with this? How do we deal, do we want to send all of these people for surgery knowing that we may only find about 20% of malignancies? Is that appropriate? So I brought some pictures. Let's take a look first, cytopathology-wise, at what we see in a malignant diagnosis. So this is a malignant smear. This is a papillary thyroid carcinoma. First things to note here is how very, very cellular this smear is. So from low power, each of these blue blobs that we're looking at here are large fragments of tissue. Then when we look at a higher power, we see, unlike that benign fragment that I showed you earlier, the nucleus, so each round circle here is overlapping. So this is a very, very crowded group of cells. They're sitting on top of each other. We see a lot of variation in the size of the cells. So one cell is small, one cell is big. The architecture here is very crowded. And then they have prominent internuclear inclusions, which we can see better on another stain. So this is also a papillary thyroid carcinoma. And then, I don't know if I have a pointer. No pointer. Ah. We'll use a finger. Right here is an internuclear inclusion. And so the point that I want to make here with this papillary thyroid carcinoma is there's very specific cytomorphologic features. There are things that I look at when I look at these slides, and any cytopathologist looks at, that it's almost like they're holding up a sign saying, I am a papillary thyroid carcinoma. This is not a difficult diagnosis to make. Likewise, the same thing with a medullary thyroid carcinoma. So the first thing that we see from low power here is how very cellular this smear is. Each of these large conglomerations are numerous cells. It has the same architectural atypia. It's very crowded. In a medullary thyroid carcinoma, in addition, you may see single cells in the background. So it's this combination of single cells and crowded groups. And then same thing, it has very characteristic cytomorphologic features. So instead of nuclear inclusions, medullary thyroid carcinomas have a very characteristic chromatin pattern. When I look at the nucleus of the cell, we see something that we call stippling or salt and pepper chromatin pattern. And the point that I'm trying to make here, one more, poorly differentiated anaplastic. This is an example of a poorly differentiated carcinoma. Things here, again, very, very cellular. So numerous cells all across the slide. And then when we look at these cells, we see a lot of variation in the nuclear size. So it's fairly obvious that this is not a benign follicular nodule. It's fairly obvious that this is malignant. With a poorly differentiated or an anaplastic, what we don't see are those cytomorphologic features that tell me it's a papillary carcinoma or it's a medullary carcinoma. So it's malignant appearing, but it's so de-differentiated, it has no characteristics that are pointing to one thing or to another thing. It's merely saying, I am this malignancy, but I have no differentiation. I'm not a papillary thyroid carcinoma. I'm not a medullary carcinoma. So that would fall into the category of malignant, poorly differentiated anaplastic. And so the point, yes, ma'am.
Let's say if you have a non-experienced pathologist, is there any way they can make mistakes?
Is there any way they can make mistakes? I would argue that looking at the statistics, if it falls into the malignant diagnosis, no. It's very, very unlikely. I mean, you are looking at 97 to 99%. So, there is that 1% chance that it was a misdiagnosis. But that's a very, very high rate of accuracy, 97 to 99%, if you have a malignant diagnosis. And the slides that I'm showing are kind of an attempt to show you how, I don't want to say how easy it is to make the diagnosis because that's an incorrect term, but how accurate the pathologist can be after, you have enough training, you see what this looks like. It's very, very cellular. They have very clear cytomorphologic features. It has a very high risk of malignancy. So the diagnosis of malignancy, if that is the category that the fine needle aspiration is in, it's very unlikely that that is a misdiagnosis. I mean, is it possible? Yes, there is that 3 to 1%, but it is very, very unlikely. Did I see another question?
Did these pictures ever accompany the report? I've never actually asked to see my reports ever, and I'm just wondering if the slides ever go in.
Sometimes they do. So some cytopathology groups will include pictures with their reports, and some will not. That is something where, again, it is your medical record. You do have access to it. You can certainly ask, you can either ask for a picture. Some places will not have that ability to give you a picture, but most people do. Or if you're at a place where you can actually review the slides with the cytopathologist, you are certainly welcome to do that as well. This is your material, your medical record, so you have access to it. So what about suspicious for malignancy? Like I showed you, the features of most primary thyroid malignancies are quite distinct. So why do we use this suspicious for malignancy category? So this is the category that's used if the specimen is either quantitatively, meaning not enough, or qualitatively, meaning not enough atypia, not enough features of malignancy to meet the diagnosis, to meet the criteria for a definitive diagnosis. And the goal of segregating out suspicious for malignancy from malignant category is to maintain that very high positive predictive value for malignant. So we want our endocrinologists and our surgeons and our patients to know that if you get a diagnosis that says malignant, we are 99% confident that it's malignant. If, on the other hand, we're looking at the slides and there really is a little shadow of a doubt, it's very, very cellular. Here in the background, about 20% of the slides look like papillary thyroid carcinoma, but the other 80% look benign. Could this just be reactive atypia? Could this be something else? This is where suspicious for malignancy, this category, is used. Here, keep in mind, the rate of malignancy, the patients that end up with a suspicious for malignancy category diagnosis, the rate of malignancy is still quite high, 60 to 80%. So now let's talk about these indeterminate categories. So remember what I said, that by cytopathology, there are two categories that fall into clinically indeterminate. So the two categories are AUS/FLUS, that's atypical cells of unknown significance, and then the category of suspicious for follicular neoplasm. So I'm going to take each of these separately, and please stop me if you have questions in the middle of this because it gets a little bit complicated. Atypia of undetermined significance, follicular lesion of undetermined significance. This is a very heterogeneous group. So the diagnosis that fall into this category is basically anything that doesn't neatly fit into any of the other categories. If it doesn't neatly fit into benign, if it doesn't neatly fit into suspicious for malignancy, if it doesn't neatly fit into suspicious for follicular lesion, then it ends up in this atypical atypia of undetermined significance, follicular lesion of undetermined significance. So it's a very heterogeneous group. You may end up here because it's a very paucicellular specimen. There's not enough cells. But what I do see is concerning enough that I don't want to call this benign. So that might be one reason that this diagnosis is given. Another reason this diagnosis might be given is, what if it's a very, very cellular specimen? All of it looks benign, and then on a single slide, I find two groups of cells that have characteristic papillary thyroid carcinoma. That's not enough to call that malignant. That's not even enough to call that suspicious for malignancy, but that's also not something that we can ignore, because what if the sample just happened to collect mostly benign material and then just right at the very end caught a little bit of something that is suspicious? So those are two very different smears that would both end up into the same category of AUS+. So ideally, when this category was constructed by the committee in Bethesda, they decided that ideally this should not be used that often. And they proposed that any institution should have a maximum incidence of using this diagnosis of 7%. So we are 5 to 7 years out after implementing the Bethesda system, and what we find in reality is there is huge variability in how this category of AUS+ is used both from institution to institution and even among a single institution from cytopathologist to cytopathologist. So in reality, some institutions never use AUS+, 3%. Some institutions use this category abundantly, up to 20%. Likewise, when this category was constructed, ideally it should have a risk of malignancy of approximately 20%. Well, what they found in studies after the fact is, of course, if you have huge variability in how this is being used, you are also going to have a lot of variability in what the real risk of malignancy is. So recent studies show that the risk of malignancy of a sample that is diagnosed as AUS plus is in reality anywhere from 6 to 50%, depending upon where the diagnosis came from. So you can see how this falls into this indeterminate category. One thing that is noted is there is an inverse relationship between how this category is used as with the category of non-diagnostic. So what that means is if a cytopathologist is more likely to put something into non-diagnostic, then they're less likely to have a high rate of AUS plus. If they're more likely to have a high rate of AUS plus, they're less likely to have a high rate of non-diagnostic. So we speculate that what that means is the cytopathologist, instead of calling something non-diagnostic, please get more sample, they're seeing something that's a little bit atypical and they're using AUS plus instead of non-diagnostic. What does that say about this diagnostic category? First of all, it does demonstrate that this is not an easy diagnosis for the cytopathologist to make. It means that what they're looking at on the slides does not neatly fit into another category. It's not very easy to come up with a diagnosis on what they're looking at. The second thing is this variability is probably a direct reflection on either how the sample was procured or how the sample was prepared. So remember we said there's a lot of variability that goes into how you're getting the sample and how that sample was prepared. Another thing is if the sample is prepared either poorly because of poor technique or poorly just because there's abundant blood in the sample and it's difficult to prepare a sample that has abundant blood, you may end up with artifactual distortions. So if there's obscuring blood or air dry artifact, these are all artifactual distortions that make it difficult to come to a diagnosis. So it hinders the evaluation of the slide and it hinders the ability to form an accurate diagnosis. Yes, sir?
Have there ever been round-robin studies to present the same slides to the labs?
Yes. Yep. And I have some results, consensus studies. I have further on in the study some discussion of consensus studies that are done. And in my opinion, consensus is an excellent thing to do with indeterminate diagnosis. Not very needed for a benign or for a malignant, but if it's an indeterminate diagnosis, a consensus is a great way to approach that slide. So the other category that is called clinically indeterminate is suspicious for follicular lesion. Now these are not difficult diagnoses to make cytomorphologically. These have very distinct cytomorphologic features. The cytomorphologic features that we see to call something suspicious for follicular lesion are these microfollicles that you can see. Let's see here. Oops. That was the wrong button, apparently. We're back. Microfollicles that you can see. So you see these very small clusters of follicles all combined together. The definition of a microfollicle is 9 to 15 cells, forming this tight little aggregate with overlapping. And in the background, we'll see very little colloid. So cytomorphologically, we have very distinct features that throw it into this category. So why is it considered clinically indeterminate? It's considered clinically indeterminate because cytology cannot distinguish between a follicular adenoma, which is a benign neoplasm, a follicular adenomatoid nodule, which is not even a neoplasm, and a follicular carcinoma. To make that distinction, what you need is the architecture seen on a histology slide. So by cytology, all we get are these little microfollicles. So by histology, and it's not projecting particularly well, but what you see here is this is a histologic slide. So this is a tissue section, and you see all these tiny little microfollicles all joined together. So this is a follicular neoplasm. You can see how if you put a needle in this and pull it out, you're going to have a cellular smear, and you're going to have all these tight little microfollicles. We can't make the diagnosis of malignant on that because what you need to call something a follicular carcinoma is either metastasis, invasion into the capsule, or lymphovascular invasion. So this is a picture of lymphovascular invasion. What we see at the bottom of the screen is a blood vessel, and sitting within the blood vessel are these little follicular cells. So the reason this then is an indeterminate diagnosis on cytopathology is we can't tell by cytopathology where the cells are coming from. We know they're coming from your thyroid, but if you pull it out of a vascular space versus if you pull it out of the nodule, I can't tell where those cells are coming from. We need to see it in a vascular space to call it a follicular carcinoma. So it's clinically indeterminate because the test is inadequate to make a diagnosis of follicular carcinoma. It's adequate to make a diagnosis of follicular lesions, suspicious for follicular neoplasm, but we can go no further with cytopathology. At that point, you absolutely must have the architecture of a histology specimen to determine, is this a benign lesion that's not even an adenoma? Is this a benign neoplasm, or is this actually a follicular carcinoma? And then what are the categories? How does this end up breaking down after somebody with the diagnosis of suspicious for follicular neoplasm does undergo surgery? Approximately 35% of these are not neoplastic. They are merely large dominant nodules in the setting of a nodular goiter, or they're a single dominant nodule. About 50% of these are benign neoplasms. So if you get the diagnosis of adenoma, it's a benign neoplasm. This is a neoplasm that does not have the capacity to metastasize. It does not have the capacity to be malignant. And then a very small percentage of these are malignant, about 15 to 30%. And of note, the majority of those that are malignant are not follicular carcinomas. They're follicular variants of papillary thyroid carcinoma. So I think the question that many of you are wondering is, when should I consider a second opinion? And so looking at the statistics here, if you get a diagnosis of benign, like we've shown many times, if the diagnosis is benign, 0 to 3% of these, if you do decide to undergo surgery because the lesion is quite large and compromising the airway, the majority of these will be benign. So it's probably not something that needs a second opinion. If you have a diagnosis of malignant, it's the same thing, just like I showed earlier. The cytomorphologic criteria that go into making that diagnosis of malignant are so very clear. It's not an ambiguous diagnosis that getting a second opinion probably is not worth the time to wait for the second opinion, the money to pay for a second opinion, the effort that goes into it, the worry as you sit and wait. It's probably not worth it because the risk of malignancy is very, very high. We're very accurate with that diagnosis of malignant. What if the diagnosis is inadequate? Is a second opinion going to help? Probably not very likely because the cytopathologist can only work with what they have on the slides. So you can show the same slides to 50 people, but if there's not enough cells on the slide, there's not a lot that you can do with it. And this is where it becomes very important to get your report and look and see what the comment is. Because if you're reading the report and you see something that says minimal cellularity or paucicellular specimen, so the diagnosis is indeterminate, AUS plus, but you read the comment and it says paucicellular specimen with rare atypical cells. That paucicellular part, that minimal cellularity part, really should point you in the direction of getting more tissue as opposed to sending that slide to an additional cytopathologist. Because again, you can only make the diagnosis based on what's on that slide. Same thing, if you read a comment and it says, this is atypical because of abundant blood, air drying artifact, obscuring artifact. These are all key words. Obscuring, blood, artifact, air drying, those are key words that I would argue you're probably best off getting a second sample as opposed to spending the time, the effort, and the money to get a second opinion. And that leads us into, now you have indeterminate. You have suspicious for follicular neoplasm or you have AUS plus. And here again, you have a number of options before sending that slide to another cytopathologist and getting a second opinion. The first option is consider repeating the sample. Over 50% of preparations, over 50% of patients that have a diagnosis that's considered indeterminate on a repeat sample will be given a definitive diagnosis of either benign, malignant, or suspicious for malignancy. So the first step might be to repeat the sample. You might want to consider ancillary testing or molecular analysis while you're repeating that sample. So if it's a follicular lesion of unknown significance, Afirma testing might be the best bet to go as opposed to sending it to a second person. On the other hand, depending upon what you want to do with this information, consensus really is not a bad idea, and there's absolutely no cytopathologist or pathologist out there that would be offended if you wanted to, take your slides and have it looked at by a second person. And that leads us to some of the studies that have recently been done. These are a couple of studies from 2010 to 2012 that looked at second opinion cytopathology. Park found, he reviewed close to 1,500 patient FNAs. This was at a single academic institution. I think it was a 2-year study. And they found a diagnostic disagreement in close to a quarter of the cases. Now then he went on to find that a relatively small proportion of those cases that had the diagnostic disagreement had a change in management with that diagnostic disagreement, but it was still high enough. It was about 10% had a change in management with that diagnostic disagreement. In another study that reviewed close to 1,000 cases, they found a diagnostic disagreement, and again, this is at a single institution. These are not sent to different institutions. These are reviews at a single institution. They found disagreements in approximately 13%, or exactly 13%, and of these, 44 cases had major disagreements, meaning a change in management plan, and 78 had minor disagreements. In another study in 2010, and this one was published in a surgical journal, what they found was that routine second opinion, so every time a diagnosis was made, a consensus was formed. It reduced the rates of false negatives, and then it consequently reduced the rates of diagnostic thyroidectomy. So what this data shows us is that second opinion cytopathology, particularly for cases that are considered indeterminate, it can be very, very helpful to come to the right diagnosis. In one of these studies, in the first one by Parks et al., they did find that after changing the diagnosis, one patient did undergo an additional treatment that was not needed. So the majority of the changes of the diagnosis were made in the correct direction, but there was one person who ended up having the diagnosis upped, I should say, and ended up getting a surgical treatment that was not needed. So the point of that is, there is some risk that you're changing your diagnosis from what is, gold standard correct to now gold standard incorrect. But what they did find is that with the majority of these, when people sit down and look at the slides together in a consensus and kind of discuss it together, these very difficult cases are more likely to be pushed into the correct surgical management or the correct clinical management. And the other thing that I would say before you start considering a second opinion, probably the most important thing is, what are you going to do with that second diagnosis? Have you already made up your mind that a risk of malignancy of 15 to 20% is not acceptable and that you're going to undergo surgery regardless? Then, what are you going to do with that second opinion? Are you going to change your mind? Before you spend the time, the effort, the money, the stress of waiting for it, if you know that you've already made up your mind, there really is very little point in getting that additional information. A second thought is, are you willing to pay out of pocket for this? Because unfortunately, many insurance companies will not pay for a second opinion just because the patient has decided that they want one. So is this something that you're willing to pay for? And then finally, keep in mind that if you are transferring care, so if you got your diagnosis at one institution and you're transferring care to a second institution, almost all transfer of care requires a second opinion or a second review of the slides. And the reason this is done is that most institutions will not begin treatment until the pathologist and the cytopathologist at their institution have reviewed those slides. This is kind of a safeguard for the surgeons. They want to ensure that before they go in and do surgery, that surgery really is appropriate and confirmed by the cytopathologist at that given institution.
How long those slides are found? Like how long do you keep them left in one institution and
So wherever you have the slides initially looked at, cytopathology slides are by law required to be kept for 10 years. And then if you decide that you want, so let's say that you had a thyroid fine needle aspiration done at the University of Colorado, but you've decided that you want to have your surgery done at home, wherever home is. Maybe you live in New York, so you decide to go to New York. The New York clinic or the New York hospital will then request the slides from where you had it initially done. The slides will be mailed to them by courier, and they can be held at that institution for a month or two, and then they are sent back to where they were originally performed and kept for 10 years. Yes, ma'am?
Is it routine that most places just do have a cytopathologist or a pathologist review the slides? They don't typically do a little group review? So-
It is, yes, it is routine that most cytopathologists will just independently review the slides. But having said that, keep in mind that, so I'm a cytopathologist at the University of Colorado. I have 3 cytopathology board certified colleagues that I work with. If it's a diagnosis of malignant, by our regulations, we have to have a second opinion for a diagnosis of malignant. So we show that to another person. If it's a diagnosis of indeterminate, I'm going to show this to one of my colleagues because this is a very important diagnosis and it's a very difficult one to make. So typically on your cytopathology report, you may see somewhere down at the bottom of the report, Dr. So-and-so has reviewed selected slides and concurs. You have already gotten a second opinion there because that individual has shown it to another person. Unfortunately, if you're a cytopathologist and you're working in a very small community, you might be the only cytopathologist there. And in that case, if it's something that's very, very difficult, we still might package up the slides and send them to an expert person who we trust that, perhaps somebody that trained us and say, could you please help me with this diagnosis? So you may be getting a second opinion without ever asking for it. Yes, sir.
With taking a biopsy with typical cells compared to benign, what's the percentage difference you would find with the biopsies done? How many of them are actually benign compared to indeterminate or atypical?
I'm not sure I understand exactly what you're asking.
In other words, if you take 100 biopsies or 25% benign and 15% indeterminate and another 20% suspicious and
Right.
last
Right, I see what you're saying.
10% malignant. So I get an idea there, and also those that are atypical, like I have.
Right.
Get ready for another biopsy, it's going to make a big difference.
Right.
What is the future chances, roughly, of that going on and developing, or most of the time they just stay the same? I know that it depends on the nodule size.
Yep. So probably the highest proportion are benign, but keeping in mind that most benign lesions are not biopsied. So if the radiologist can tell that this is benign, if the clinician can tell it's benign. So the highest proportion of lesions that we see, the diagnosis is benign. Probably maybe 10 to 15% come into the diagnosis of malignant, with the majority 60, 70% being benign. It's that atypical, the indeterminate category. And like I said earlier, that range is very variable. It depends on the institution to institution. So it can range anywhere from 3 all the way up to 30%. At the University of Colorado, I've done a study at the university, and our incidence rate of calling something indeterminate is 15%. So if you come in and you get a biopsy, you have a 15% chance of getting it indeterminate.
And you find those later.
The next question is what percentage of those can be put into a determinate category? On repeat biopsy, 50% of cases can be put into a more definitive category on repeat biopsy. So you have that initial indeterminate, and then it goes into, 50% of those. 50% of those are still indeterminate. If you've been considered indeterminate 3 times in a row, chances are you will be considered indeterminate. That biopsy has characteristics that are just troubling enough so that it doesn't fall into one nicely or the other. And that's where molecular analysis can really be helpful at that point, because if it goes for molecular analysis, say Afirma testing, and that comes back as low risk, that bumps the nodule back down into the benign category and can be clinically considered benign. Yep, and that's definitely the next step. Yes, ma'am.
No,
5 minutes. 5 minutes, any questions, anyone? Yes, sir.
So is a core biopsy cytopathology or histopathology?
A core biopsy is histopathology. It is not the gold standard for a thyroid. If, on the other hand, it is being used for a lymph node, then that is acceptable. Why are core biopsies no good for thyroids? It's because of the way a thyroid is made. The way to think of a thyroid is basically an organ that is composed of lots of little balloons, and each balloon contains colloid. So if you put a needle in it, you can collect the cells and you can collect the colloid. If you core it and try to take a small chunk of it, it all collapses. So a core biopsy is definitely not the standard if you're getting a thyroid lesion looked at. But if you're getting any other lesion, a core biopsy is perfectly acceptable.
So how often when you're doing a second opinion, do you get to see the first opinion when you do a second?
Absolutely, absolutely.
How often does it, because the person who took my sample said you should get a second opinion. And I was under the impression the sample was done well, and I was wondering if, I didn't look at my report, but do you get second opinions that say, you would have said get another sample before you get a second opinion?
We do. So if I, at the university, if I'm reviewing a case that has come to me from an outside clinic, I will definitely write a little note back to the clinician, the pathologist or the cytopathologist, and make my recommendation. So I would, explain why I see what I see and how I came to my diagnosis about that. The other question is, with second opinions, benigns are not likely to be changed, malignants are not likely to be changed. It's everything in the middle. And if you bring your slides to a different person, the chance of having the diagnostic category changed is actually around 20 to 30%. So it's all that stuff in the middle that causes that low sensitivity. But then again, the next question is, what are you going to do with that information? You really need to use it all together. Other questions? And I'll stick around, right outside there. So if we run out of time and people have additional questions, I am here as long as you have questions for cytopathology. Yes, ma'am.
Some of these tumors that say 2.4 centimeters, and they're digging into it for an FNA. How much of that 2.4 is got cancerous cell? Do you know what it is? The whole block jam-packed.
Yes, and that.
A bunch of dodgy stuff, but they're trying to get a needle in the haystack.
It definitely depends on the tumor, and this is where reading the report, because as you saw for that follicular neoplasm, if that follicular, and the slide that I showed was a follicular carcinoma, so that is all tumor. On the other hand, a papillary thyroid carcinoma could be a large lesion, but just because of the way it's made with these little papillations and abundant colloid, so although there's tumor cells in there and it's a 2.5 centimeter nodule, it's not jam-packed full of cells. So it definitely depends on what type of cancer it is. Likewise, with an anaplastic, you may see necrosis in there. You may see, just background inflammation. So the size definitely gives you an idea of the extent of how much tumor is in there, but a lot of it is just looking at the pathology report. Did that answer your question somewhat?
Yes, somewhat of the things you see a slide of the whole chart.
Absolutely, and this is something where you can definitely find out who the pathologist is and ask, may I either review the slides with you, or I'm curious, could you please take a picture and send me a picture of the tumor? And many institutions now will put pictures of the tumor into the report, but if they don't, there's no harm in sending that person an email or calling them. we are very humane people on the other side of that microscope, and, you know, we're absolutely welcoming anybody that has questions or anybody that would just like to see their slides. Well, thank you very much. I'll stick around outside for additional questions.